Okay, perfect. All right. Dear guests, welcome to the PhD defense of Dr. Faith Robertson. My name is Daisy, and I'm one of her two paranymphs. I'd like to tell you what you can expect in the next hour. Before the actual defense ceremony starts, Dr. Robertson will give you a 10-minute summary of her research. At that time, there will be no opportunity for questions. After the summary, please remain seated until the beadle and the examining committee enter. The rector will then open the defense, which will last exactly 45 minutes. I now yield the floor to Dr. Robertson.
All right, thank you, Daisy, and welcome everyone. It's a beautiful building that we're in today, and it's just a beautiful day to have so many friends and family with me. So, as mentioned, this is a general talk to really shine a little bit of light on what I'll be grilled on for the next 45 minutes. And it's about global neurosurgery. So when you think about global health, oftentimes we think of things like infectious disease, such as tuberculosis, malaria, or HIV. And for many years, that was the focus of global health. But in 2015, a large commission, the Lancet Commission on Global Surgery, showed that actually surgery was the neglected stepchild of global health. That was a quote by Paul Farmer. And while we didn't address a lot of building surgical infrastructure before because we felt it was too complicated or too expensive, we found that while it would cost $480 billion to really bring the world up to par on surgery, the savings would be $12 trillion. So this is actually an incredible investment. It's just going to take a lot of organization. My focus has mostly been in neurosurgery, and the reason for that, you can see the map on the left, shows the global neurosurgery workforce in 2016. Throughout sub-Saharan Africa and Southeast Asia, there's usually only 0.01 neurosurgeon per 100,000 people, whereas the recommended ratio to the population is 1 per 100,000, so really 1/100th of what we need. And then the map on the right shows how many cases a surgeon in that area would have to do in order to meet the demand. I currently work 80 to 100 hours a week and do about 500 cases a year as a trainee, and that would only put me at that line just at the end of the green zone. So you can see in the red, doing 10,000 cases a year with the current workforce is really untenable. This is a timeline I have in Chapter 9 of really a lot of the major events about the global neurosurgery movement that have happened over the last decade, starting with the Lancet Commission in 2015. In 2018, we had a series of papers in the Journal of Neurosurgery. I was first author on one of those, including things like the policy recommendations, World Health Organization, and World Health Assembly legislature, and so on. So you can look in Chapter 9 for more interest in those. But this is somewhat fortuitous because a lot of this spans my time in medical school, my master's, my neurosurgical training, and my PhD. But most of the PhD happened fairly spontaneously because of this meeting and this day. I was in my master's in London, got invited to come to Cambridge by train to the Global Neurotrauma launch. And Marika Broekman, who's my promoter, who you'll see shortly, was passing through potentially for a job interview. And I had known her from Boston, some collaboration. I was sitting in the back of the room, and this woman sits next to me, and it's Marika. And we were listening to some of the talks. It was about a lot of trauma, but then there was this topic about an article had come out a week before about training non-physicians as neurosurgeons in sub-Saharan Africa. And this was highly contentious. You know, is something better than nothing, or is something doing harm? And with her interest in ethics, she was like, oh, wow, there's so much here, and my interest in global health. We started talking about collaborating more for this as the goal and focus of my thesis for my master's. And here someone was giving a talk about having general surgeons assist in a different country, and this was Marika and I back in, this was 2017. So the first part of in research is to really define the problem, and looking at the workforce gap was 23,000 neurosurgeons were needed in low and middle income countries to meet this gap. The idea of having a non-neurosurgeon do it, again, was debatable, but we kind of parsed it into these two different areas. Task shifting, which is when you train an individual, a general surgeon, a non-doctor, a general practitioner, and then send them on their way, versus task sharing, which is training that individual, and then having iterative communication about patient management, surveillance, outcomes, and it's really a loop in terms of ongoing continual improvement. So started by trying to understand how prevalent is this in the globe. So sent out a global survey to 47 low and middle income countries responded. Of this, I think the most surprising thing is that this was happening in 42% of the countries who responded. So even if this is an underestimate of reporting, it's still a lot more than, it's clearly showing that this is a problem that needs to be addressed. More importantly, there was very little structure, very little competency-based evaluation. There was a range of who was actually doing the task shifting and sharing and what procedures they were doing. So then we talked to the whole globe, high-income countries included, to gauge what are perspectives on this. If we want to add some infrastructure, what kind of guidelines or rules or policies should we implement? And this really helped us parse out kind of with an agree, disagree type of plotting to form what would be a potential ideal model if you're going to have non-neurosurgeons do this care. And it's structured teaching and training, adequate oversight, competency-based evaluation, things like adequate referral networks and a very clear scope of practice, as well as recognition by the system and financial compensation. And it sounds somewhat crazy to think about this, but when you think about the US, we do this every day with our anesthesiologists and our current CRNAs, so certified registered nurse anesthetists. And many of the cases I do are actually not with an anesthesiology attending. There's just one supervising 5 or 6 rooms with these nurse anesthetists. So this is something that happens. It's just it needs to really have structure, certification, remuneration. Then I went out to find where this was potentially occurring close to the ideal model. I spent 4 months in the Philippines studying where they were training general surgeons to handle emergency trauma care. In the green are areas where they were really quite aligned with the ideal model. Yellow, there's some improvement to be made, and red, kind of lacking that. But with this type of approach, we saw that there was no significant difference in mortality of the patients when there was adequate oversight. Some of my work has then gone into inform policy. So the comprehensive policy recommendations for head and spine injury in low and middle income countries, and these are the World Health Organization charts. When you think about building a system, there's finance, there's structure, there's information, there's across the top, there's the actual pre-hospital care, hospital care, rehabilitation, and then my call out is task sharing is preferred over task shifting, and then there's a sub-chapter within that full document. When COVID happened, Marika called me and said, we're all being task shifted and sharing. I became a medical doctor in a COVID unit instead of a surgeon. And these were, again, applying that triphasic type of model of a training, practice, and maintenance phase, a way to really approach these type of things when really this is when the demand for patient care outnumbers the supply of providers. And that's when you can enter this mentality of this concept. Looking forward, I talk about, what are creative ways we can approach training up more of the next neurosurgical generation, as well as task shifting or sharing providers. And there are great things about spaced repetition learning, using simulation, and really tapping into the other 50% of the population, the women, who are often underrepresented in this field. So with that, I want to thank you. And really, most of this, as I said, has been a journey with Professor Broekman, who we've collaborated in many things remotely. We've met up all over the world, Dublin, Boston, here in the Netherlands. Some of you in the audience are in these photos as well. So it's really just been an incredible journey. And I'm so excited to be grilled in front of you now and have you all witness this and take this next step. So thank you.
Thank you for the summary of your research, Dr. Robertson. For the audience, please remain seated, and the Beadle and the examining committee will join us shortly, and then the rector will open the defense.
Welcome all, esteemed candidates, your paronyms, members of the examining committee, and everyone present here today, both in this grand auditorium and online. Please have a seat. Esteemed candidates, you are standing before a committee duly appointed by the doctorate board, which is now assembled to discourse with you on your dissertation and the accompanying propositions. The discourse shall be commenced by Professor Rousseau, who is online, and she is a clinical professor of neurosurgery at George Washington University School of Medicine and Health Sciences in Washington, D.C. It's early in the morning, Professor. Welcome. Thank you very much for participating. The floor is yours. Professor Rousseau.
Thank you very much. I am delighted to be here with all of you. I'm particularly delighted to have this opportunity to interact with our esteemed candidate, Faith Robertson. So esteemed candidate, I'm going to begin with a topic that you have published about both in your dissertation and throughout the medical literature, that is on task shifting and task sharing. This is a very important topic, as we all know, in neurosurgery, because there are many places where there aren't neurosurgeons at all. I believe our own work showed 29 countries and 14 territories with not a single one. So your work is very important, but I would like to ask you more about the initial survey that you did that comprises Chapter 4. You had 127 responses from 46 LMICs. So, esteemed candidate, can you tell us more about whether or not you believe this is an adequate response rate, an adequate amount of information to be able to generalize about what the global neurosurgery community should be doing in regards to task shifting and task sharing?
Well, hello, opponents. Thank you for that question, and thank you for being here, Professor Rousseau. I think it's an excellent question. One of the major limitations to when you do a survey study is response rate, especially when you can't really ascertain the denominator. So the way we sent these out was a lot through social media, email listservs, talking to the different neurosurgical societies, in the Europe, the U.S., the Asian, European associations. And in theory, that could have hit the eyeballs of many individuals and many neurosurgeons. So the response rate is quite low, probably like less than 1%. So I think it's extremely limited in that. But I think what it still shows us and why it's still valuable, it shows us a cross-sectional snapshot that I think was surprising, that it was being done more than we were thinking when we were discussing these things with the neurotrauma launch in 2017. Especially in the context, to add some color to it, when I started reaching out to different countries to see if task shifting or sharing was occurring more as an interview type of question, and to see if I could move there like I did for the Philippines to study in more depth, many countries actually confessed to having this practice, but they had fear about it being studied in case they were one of the first case studies and in case what they were showing was doing harm instead of doing good. So I think that while ideally, and I think I stated this definitely needs to be followed up and hopefully more robust or maybe interview style or get a better snapshot, it did elucidate that this is a real problem and it's ongoing in many countries without much oversight or infrastructure.
Thank you. It seems very important, and we look forward to your follow-up on that and the impact of such an important study, both in the Philippines and around the world. I'd like to turn now to Chapter 9, where you discuss the role of policy in global neurosurgery. And in this area, I'd like to be sure before you are hopefully awarded your PhD that you're aware of some of the additional organizations that have been very involved. There's in particular a movement that created the first ever neurosurgeon sponsored resolution at WHA, which was in 2023. You mentioned it briefly, resolution 76.19 on micronutrient
Mm,
fortification.
yeah,
This is
folate.
important. It's important to recognize the role of the International Society of Pediatric Neurosurgeons and the G4 Alliance in that. And I'd like you to address the policy implications of neurosurgeons in 2023 for the first time getting a resolution passed to prevent a neurosurgical condition and what implications for further involvement of neurosurgeons in policy that may have.
Yes. Thank you for pointing that out. And so I agree. I think, you mentioned the WHA 79.1. I think a key thing, the WHA 68.15, which was passed the World Health Assembly, was really highlighting the role that many of these surgeries actually are essential parts of healthcare. So that was one of the earlier policies that was discussed by the World Health Organization, that this should be at the forefront, that surgery should be one of the important things we focus on, and that was more broad. And then the later one, so some of us had been talking, so the supplementation of folate into is one of the main micronutrients that are being addressed to really avoid, in the prenatal period, the development of spinal bifida, or incomplete formation of the notochord and spine, which can lead to many different side effects and conditions, myelomeningocele, many repeat treatments, inability to walk. So in the United States, all of our bread and many of our carbs are already fortified by this, but it's not actually done across the world. So it's ironic that neurosurgeons would be, doing this, as you're saying, to, take away some of our need for treatment. But I think what we're kind of doing in every area of neurosurgery, whether you're in the lab, whether you're in policy, or whether you're just operating, is your goal is to make yourself out of a job. Is really to treat all these things. And the earlier you can, I always think prevention is better than treatment. If you can,
Yeah.
have a disease that you have the ability to mitigate it before it starts, I think it's, way more cost effective. It's way more effective from a health system standpoint. So I think, some people will also talk about neurosurgery still in the broader concept of all surgical burden of disease is small, but it's so valuable to have neurosurgeons at the helm in these rooms, like with policy, for some things that are neurosurgically related, but also I think a rising tide floats all boats, and neurosurgeons have a lot of energy. And I think we, really focus on developing, when you build up an operating room or a CT scan and that, you really elevate the level of care throughout that hospital, region, or country. So I think it's critical. It's amazing work that you've done with G4 Alliance, with the World Health Organization, and I think we just need to continue to keep that involvement, especially with the current political environment where, as many of you know, we've recently rescinded our dedication as the U.S. to the WHO. So I think more and more as individuals and separate private groups have to lean into that and make sure that we stay involved.
Amen. Let's turn now to the information that was provided in Chapter 10 of your dissertation about investing in the future, and in particular, the role of women in neurosurgery. And although it's gratifying that your research shows that there's an expansion of women in the profession, 80% of healthcare is delivered by women who are non-doctors, right? They're allied health professionals and nurses. Do you have any ideas from your research about how we can involve the non-neurosurgeon women who participate in neurosurgical care to better serve our patients?
Sorry, a clarifying question. To still bring more women into neurosurgery or empower those who are doing adjacent
Both,
jobs?
both. We know that globally, 80% of healthcare is delivered by women, by gender, rather than men. And a small percentage of neurosurgical care is delivered by male and female neurosurgeons. If you look at around the clock, a lot of it is, most of the care is the nursing care.
Mm-hmm.
How can we encourage higher quality and more neurosurgical nurses and allied health professionals to help us close this gap of the 23,000 missing or deficit of neurosurgeons we currently have.
Yeah, I think so. I think we do need to address both. I think if you're, I think first I'll just address like bringing more women into neurosurgery. I think is something that there are a lot of different systemic things about training that need to be addressed, whether it's additional support for maternity, just recruiting and having mentorship. So when you are the only woman, you still can talk to people in different countries or some of the different challenges you're dealing with. There's training on negotiation, a lot of these different things to bring in more women into the field and make sure that they're supported and that they don't leave that post once they get it. I think when we talk about the ancillary care, there's a lot of different examples. So in Malawi, where they have these technicos de cirugía, so a lot of the people giving the obstetric care are clinical providers, but they're non-doctors. And most of the babies in Malawi are actually delivered by these individuals who did not go to medical school, but they got the exact training, and they have a great task shifting and task sharing model, more of a task sharing model, where they actually get certified. It's a shorter training program because they're focused on a very niche area. There's clear task scope to prevent task creep. So they're not, at first, the obstetric gynecologists were nervous about them taking over their care, but there's so much burden of disease, and it was such a narrow focus, they've actually empowered a lot more of their workforce, and many of those, I believe, are women. So I think you can do similar things with, training in the ICU and, making sure that the critical care and the post-op care is handled quite well. Or even, it could be just training people on how to do the exact, Burr-Hor craniotomy. I still believe when you task share in neurosurgery, it's better to go to a general surgeon because they have that practice in clinical decision making. They know how to suture, they know how to irrigate, cauterize, and all the basic principles are there. That's why I'm hesitant to have someone who's total non-doctor be trained in these things. I think there's so many foundational layers that are better if it's a general surgeon. But I think we can empower women in all aspects of that.
Okay, I think I'm going to interrupt you. Thank you very much. Sorry to interrupt you. We have to stick to time. Thank you very much indeed. Thank you, Professor Rousseau. You will be back at the end of the ceremony, so hang on there. Now the examination will be continued by Professor Dankelman, who is a professor of biomedical engineering at the Department of Gynecology at the Leiden University Medical Center. Professor Dankelman.
Because trying to improve surgery in lower and middle income countries is really important. You do this specifically for neurosurgery. Well, we try I'm also from the Delft University of Technology. Together with some engineers, we try to do similar things, but then more in general surgery. But what we try to do is look at from a bit different point of view, from the engineering point of view. Now, in chapter 2, I would like to discuss with you, because there you try to investigate what are the barriers for neurosurgery in lower and middle income countries. And one of the things that you figured out, that also one of in a table on page 27, you indicate that also there's a barrier for lack of access of equipment. Now, assume that we, within a group of engineers, are willing to help you to bring surgery in neurosurgery in lower middle income countries. What do you think, what is needed to cross the barriers?
Ohaler de opponents, thank you for your question. And I love engineers. And I think that the way they think through problems is slightly different than many of us that are more clinically trained. And seeing the whole picture and seeing things as a systematic problem, I think is the engineering mindset. And also, it's hugely important. As you're building up operating rooms, you put a surgeon in an empty operating room, we're pretty useless without our tools and gadgets and everything. What I've seen in some of my travels, so in Rwanda, I worked a lot in general surgery, looking at laparoscopy and that. And one of the main things is even when you get new equipment, you need biomedical engineers there to service it and keep it up. Same with the hospital has a CT scan, but it's been broken for 3 months because you don't have the biomedical engineers to fix it. So I think really the best way forward for a lot of this, when you talk about systems level development, I think there are different tiers to approach it. I think you do need policy level, but when you start getting down more to hospital level, I think it's really good to have institutional or academic partnerships where you're bringing not just surgeons, but also biomedical engineers and these things.
I fully agree on that. So we developed also, for example, massive online training course specific for biomedical equipment technicians and biomedical engineers. But is there specific for neurosurgery that is different from global surgery, of normal from general surgery? Is there some specific where you say we can start tomorrow with a project together?
I think one of a key thing that comes up in neurosurgery is navigation. In general surgery, there's a lot more of what you can expose what you need to see. In neurosurgery, we rely quite heavily on like a GPS system for the brain, whether that is using a high-resolution MRI, so even the MRI itself, and then mapping that onto the patient's head. And there's, whether it's fiducials or there's new technologies coming out, but I think neurosurgery is unique and really relying on that navigation aspect. Alex Golby, a neurosurgeon at Brigham and Women's Hospital in Boston, has been cited by developing NewNav, which is like a cell phone device to help with that. There are some people working on things, using the fluorescent dye, 5-ALA for brain tumors, and then creating a cell phone or a certain microscope adapter, microscopes themselves. So a lot of it in neurosurgery, it's more about visualization and what can you view. And it's always striking to me when I go abroad and they have a printed CT scan from a few weeks ago, or no actual navigation, so you're just drawing and marking out on the patient's head, which can be okay if you're just evacuating an emergent epidural hematoma. But when you get to more delicate surgeries, more advanced surgeries, you're going to need higher technology.
Okay, thank you very much. Then I would like to discuss chapter 8, in which you because also the title, Role of Technology, that triggered me. But in this chapter 8, you did an investigation and what the effect is of training, of using a phantom and rapid training. I was wondering, because you did, they had a pre-test, and then they did the training, and there's another post-test.
Mm-hmm.
But the control group did nothing. And I thought, yeah, of course, training helps. So it's kind of obvious that it helps.
Mm-hmm.
Would it not be having better that the control group did also some, for example, looking at extra videos or so, something that had also extra training, but not the phantom and the faculty-guided training?
Right, so along the background, for the context, it was neurosurgery residents working on the simulated model. And this is in addition to our surgical training. So people are still operating 5 or 6 days a week, some of them doing the pterional craniotomies and stuff. And then everyone took the pre-test, everyone took the post-test, and the other group worked with the simulators an additional 4 times. So you're saying it might not have been the perfect control, but the idea was if you had been exposed to something once and then 6 weeks later versus spaced repetition learning, that you would improve that with time. And what it highlights is really the decay in learning. The decay curve after learning decays rapidly after you learn something. When you do spaced repetition learning, it starts to decay, and then it'll continue going up and then plateau. So you could argue there would be a better control of teaching them something different, but I think it's more the cadence of the teaching and with the simulator models.
Okay, thank you for your answers. I would like to give the word back to the director.
Thank you very much, Professor Dankeman, for sticking to time as well. The examination will be continued by Professor Schucht, who is online as well, because he is in Bern, Switzerland. Thank you very much, Professor Schucht. You are the head of neuro-oncology at the University Clinic for Neurosurgery in the Inselspital in Bern, Switzerland. So it's up to you. Professor Schucht.
Well, thank you very much. Esteemed candidate, first of all, I would like to congratulate you. I was told not to do this too extensively, but I would like to congratulate you on the work you've done both at home and abroad. which I think is very laudable. I would like to focus on the chapters 5, 6, and then going forward 10. But mainly I would like to lead you away from the work you've done to times of crisis. A lot of a lot of the work you describe happens in calm times. Your thesis highlights the effectiveness of task sharing, twinning programs in addressing the neurosurgical workforce shortages in these countries. But what do you see as the biggest challenges in practical implementation of these strategies in case of political instability, lack of regulatory support, cultural resistance to that work? How is that affecting task sharing, in your opinion?
Ohaleerd opponents. So I think there's what you're pointing out is, yes, there's difference if this is a calm environment, you can anticipate long training, structured training, etc. I think the default is task shifting and sharing happens in those times of crisis because it's just a way when the demand is outstripping the supply, and that's when we see it's less structured. If there's political resistance to allowing this, I think then that's a key. This is where it comes into shared decision making, whether it's at a national level, if countries are willing to support this type of thing, if it's more regional. In the Philippines, where I was working with Professor Lynn Lucena, she first got the approval for this at the National Filipino College of Surgeons, and then started giving more talks on it. And at first, some people were skeptical, but over time, as it was structured, more and more people, were accepting of this type of policy. But I think it is key because just as what drew me to it is a highly contentious debate of some people say, well, this is going to take away from the bona fide trained neurosurgeons, or who takes on the liability? Is it the neurosurgeon who's overseeing these individuals who are task sharing, say they're general surgeons? Where does the ultimate liability lie? And that gets more important in highly litigious countries. But again, we do this with anesthesia in the US, which is probably the most litigious country that exists. So I think it's a conversation, and it depends on what the true need is at that time. Is it one of the more pressing needs? Are you able to garner political support for it? And if so, then even if it's a rapid requirement, you can still implement some type of structure with it.
Very good, very good. So I'll be especially interested in, let's say, strategies to mitigate these challenges. You've mentioned you've done some work in Rwanda. Now these twinning programs, they depend on this international collaboration. We've seen it in Rwanda, where everything gets disrupted by unforeseen political instability. What do you see as mitigation strategies or potential strategies? And now let's move towards twinning projects. Things like digital training, mobile surgical units, missions, unplanned, emergency focused twinning models. How do the importance of these strategies change in case of political disaster?
Yeah, I think so. One of the twinning programs, I haven't gone over with them, but I'm familiar with Duke's twinning program in Uganda. And each time you go, your goal is to make yourself less relevant. So they're training individuals up, and I was talking with Mike Hagland, and during COVID, they weren't allowed to travel there. So it was, an epidemiologic instability as well as political. And they were still able to ship the equipment for their planned trip, but actually the surgeons had over time already gained the independence to be able to do those cases without the US surgeons. I think we've also, with COVID, all started learning, the power of telemedicine, telecommunication. Some of these simulators, the simulator I used for my study was Upsurgeon. I'm very close with Federico Nicolosi, the CEO. And there's a lot of virtual things you can do with that, shipping the models and then actually shipping one VR headset and actually having people run a course remotely. So I think there are ways to still, in political strife, if the barrier of the political conflict is actually having other individuals travel to the country safely, I think there are ways around it. And a lot of them actually, a lot of ingenuity came out of the COVID era. But I think if it's more political, saying we actually, if the hospital's blown up or something, as we're seeing in certain parts of the world, I think that's much more challenging.
Excellent, excellent. Now, some of us have such type of programs running at the moment, and we encounter these kind of disasters. Do you recommend us to have some contingency plans in place? You mentioned COVID. What are the lessons learned we should kind of have us already ready in our programs for unforeseen disasters?
I think, can you, I guess, tell me a little bit more about what type of disaster you've experienced, or?
Let's say military coup.
Okay,
when
military.
your normal, the people you work with suddenly are not there anymore. They're not in charge anymore.
Mm-hmm. Yeah, I think you have to still maintain the safety of your clinical partners at the hospital there, and really let them guide you in terms of when it's safe, what is safe for you to continue working on. If there may be times that actually you do have to pause this and take a step back, but I think that ideally in the partnership, there's a tendency sometimes to think the individuals from the high-income country are coming in and they know more and they know better and they should be dictating and running the show, but it's really, the recipient of a lot of this really needs to be in the driver's seat, and I think they're the ones with more of a foot on the ground. If there's a military coup and it's not safe for individuals to travel, then it's just finding out how we can best support them in that twinning relationship during that time.
Excellent. Well, thank you. You responded very well to my question, esteemed candidate.
Thank you very much, Professor Schucht. We'll be back at the end of the ceremony. Now the examination will be continued by Professor de Vries, and she is a professor of normative aspects of medicine at the Leiden University Medical Center. Professor de Vries.
Thank you very much, esteemed candidate. First of all, let me also congratulate you on your beautiful work. When reading your publications, I think you're of great importance as an advocate for global neurosurgery and maybe even equity in general. So thank you very much. As was said, I'm an ethicist. Happily for any patient, I'm not a neurosurgeon. And I'm specialized in global health topics, but mainly communicable diseases. So it was very interesting for me to read also on a different agenda topic within the field. So what I would like to do is first ask one of the Paranymphe to read Proposition 11, please.
It is a mere chance that we are born into one nation versus another, and that chance has a dramatic effect on the quality and quantity of life we can access. As one born in the United States, I recognize the privilege and accept the inherent responsibility to uplift those in less resourced countries. As Jean-Baptiste Molière said, it is not what we can do for those, it is not only what we do, apologies. It is not only what we can do for those held responsible, but also what we do for those, but also for what we do not do.
Thank you very much. So I think it's a very important proposition. It's about structural inequity in access to care in general. But as you were already mentioning, we also have to be realistic that since you wrote your papers of the manuscript and the other papers, the world has completely changed. There's a new reality with the Trump administration, but also, for example, let's not talk only about the United States. Our own Dutch government, you said the USA left the World Health Organization. Gender equity is no longer a topic that can be discussed, but also the Dutch government stopped payment for development goals. So in general, it's not really going well with equity, but you still focus on that. And in this new reality, I was wondering how can we argument for that? So why should we in the high income countries actually care about people in the low middle income countries? So you talk about moral obligation, but what is your argument for the moral obligation to care for the distant needy?
Oh, hello, opponents. It's an amazing question. I think it really gets, and it's a very philosophical question. What does it mean to be human? What does it mean to have a moral duty to help others? It pains me to see how some of the world is going, and I know this might rub people wrong politically, but I'm have a lot of opposition to some of the decisions that are being made. I think there is a moral duty to, and some people find that through religion or some type of spirituality or just humanity. And I think we still need to push even harder now in these circumstances. I had the random fortune of having a conversation with Bill Gates a couple weeks ago, and I asked him the same question. And yeah, I think when we pull back from having a presence and helping lower resource settings too, I mean, it's not like there's no impact or backlash on high-income countries as well. The infectious disease outbreaks, for communicable diseases, if we're not there helping or ensuring that or people have the resources for it, infectious diseases don't respect national boundaries. National boundaries are made up. They're in our minds. They're human-made. And there's a lot of risk in this as well. So I think you can make the moral obligation argument. You can make a biohazard infectious disease or bioterrorism argument. With the role of AI now, it's not hard to actually create weapons of bioterrorism. You don't have to be that smart anymore. You can leverage a lot of different things. But I think we do need to keep pushing. I think might lean more on the private sector for this. Again, it's very disheartening, but I think that just means we need to use our voices more.
Okay, so and what I hear in your argumentation, I actually hear two arguments. So the first is maybe when you talk about communicable diseases, it's also it's self-interest. Because we're all in this together, and that's what we saw during COVID.
Mm-hmm.
But how can you relate that to global neurosurgery? Could you make the same argument? If you really have to convince both our governments in a way to somewhere, it's also in your own interest to do this.
Yeah, I think it's way more difficult to make that argument, just because things aren't as communicable. But there's always learnings that we have from other countries. So an example was, for hydrocephalus, we do something called an endoscopy of the third ventricle and choroid plexus cauterization. So boiling that down, a lot of children in low resource settings develop hydrocephalus. Some of it's from infectious cause naturally. We used to only treat these with a shunt, so a catheter that goes into the fluid space in the brain, down into the abdomen. Shunts fail often, they get infected. Then one of the gentlemen from Boston Children's Hospital was doing a lot of work in Uganda, discovered that you could actually make this small hole in a membrane of the brain and spare people from a shunt. And I use this at Mass General Hospital at Harvard all the time. And this is for any reason to cause hydrocephalus. If it's obstructive, you can do it. So there's still advanced learnings that you can get from applying surgical care in different settings. So innovation, I think, would be stalled. It's not a hard argument, but I think innovation is a major aspect of that.
Yeah, and I thought you were going more into the direction of that it also maybe has an economic benefit. So people remain healthy longer, and you can benefit from
it. It definitely does. But if a high-income country is saying, I don't care about that country, then it's not, continuing to do global neurosurgery there is not going to benefit the economics of the high-income country.
Yeah,
but
So-
it does to save them sooner there.
And then onto the other argument, because I think we both agree that it's sort of awful to have to make these sort of arguments, don't you think? And so the second argument was more in, I think, human rights or the duty of beneficence argument. And the problem I also have within my global health ethics work is that many people see that argument as, well, you know, it's a good argument, but it's not a perfect duty. So it's an imperfect duty. So someone who does it like you, and we congratulate you on that and we applaud you on that, but it's imperfect. And do you have any idea, how can we make this? I also don't know the answer, so I hope you have the answer. How can we make this a perfect duty, that there are maybe either human rights or beneficence arguments that state there are no boundaries?
I mean, if you find more creative ways to reward altruism. I mean, altruism, you can debate whether or not altruism really exists. And this is very philosophical, but, you know, is there ever an act where you don't truly benefit? We get applause, we feel good about ourselves. I mean, you could financially reward, instead of just, as you said, giving kudos here, like, are there other incentives we could be creative about for altruistic events or research? That's one way I could hypothesize, but I think it's not the way the world is going, but I think it does need to change. So,
Thank you very much. I see I have to give the word back to
thank you.
Thank you.
Okay, thank you. We could go on for a long time in
Yes,
this interesting.
sorry.
Okay, thank you very much indeed. Now the examination will be continued by Dr. Van Essen, who is a neurosurgeon at Leiden University Medical Center. Dr. Van Essen.
Thank you very much, esteemed candidate. First of all, congratulations on this PhD thesis. I enjoyed reading it very much. Felt fired up on this midpoint. Also reassuring that the Americans still invest in the underserved and low-income countries, altruistic of now or not. However, I also like to discuss some matters, some methodological matters. I'm also an epidemiologist. So I'd like to direct your attention to chapter 5. And in that chapter, you tested the hypothesis of a model where emergency neurosurgery care is delivered by trained surgical residents, so general surgery residents. It's compared to a neurosurgical model, so neurosurgeons delivered emergency care. And also observational study in the Philippines comparing 2 hospitals. And of course, there are certain geographical challenges as well as financial and infrastructural challenges. So here comes my question. So could there be another explanation for the main result of comparable outcomes between both models of these emergency neurosurgical care delivery?
Zeer geleerde opponents, thank you for that question. I will admit there are many limitations to this study, comparing a more private hospital versus a public hospital, going through thousands and thousands of paper charts. So with that, the actual accuracy of documentation, me living in archives, going through paper charts and seeing which GCS was recorded, you know, and trying to make, you know, statements based on that. The accuracy of the assessment of some of these grading systems and the actual, so I think one huge limitation is documentation. The types of surgeries people were doing, you know, we honed them into being quite similar, but still private payers were more likely to go to the Mother Seton Hospital, the private institution, versus Boston Medical Center, or Beagle Medical Center, BMC. And so, and I think also, you know, having a better powered study with a larger sample size and stuff would help as well. So yes, whenever you get a non-significant difference too, I think you have to be skeptical of, you know, was it truly powered? I mean, it seemed powered enough, but to look at different variables and the accuracy of the reporting, likely, this is why more studies need done, but it was a first attempt.
Thank you very much. Very good answer. But maybe not complete in the sense that I was especially struck by the fact that there's a very skewed availability of probably most important interventions in TBI, which is mechanical ventilation support and CT scanning availability. So along that line, and that's maybe a policy line also, if you could instantly change one aspect of the current care for TBI patients in the Philippines, what would that be?
One thing I would say is, from the personal experience there, was reliable ventilator support and a pulse oximeter with that. I think the most painful and striking thing was that one of the cases the general surgeons had finished, the case went well, there were no ventilators available because someone took one, and they taught the family members how to ambu bag their son overnight without a pulse oximeter. So when you see that, you're like, wow, they don't need more surgeons, they need, ICU level care. But those reminders are humbling, because you can come in thinking, I'm just going to fix this one thing, this is my focus, but you really have to take a step back and do it as a systematic approach. I think there's also huge ways to improve. There's a lot of non-op TBI management that's guided by intracranial pressure monitors. And the existence of those in a lot of these settings is also quite limited, just because of the cost, the electricity reliability, the monitors. So there's a lot to be done on the TBI front that's also outside or adjacent to the surgical component. And I think that's why these partnerships with biomedical engineers and really thinking of this as like a systems level capacity development, more than just human resource development thing, is necessary.
Great, very happy with that answer. I hope for exactly this. So I want to direct your attention to chapter 8 now, again, methodology. And in chapter 8, you evaluate the role of spaced repetition learning using these simulation models. We briefly discussed it already, but I'm going to take a new angle. So you compared this proficiency before and after a training phase, and the assessment was done by attending neurosurgeons, and the participants were your fellow residents in Boston. And then this independent evaluators, they were blinded to the resident groupings and the training levels. But here comes the question, were they also blinded to whether or not the assessment was done pre or post the training assessment? And in general, what are the limitations of current objective assessment metrics in capturing these proficiency and, how do you call that, like surgical readiness or so?
Mm-hmm. I have to remind myself. I believe they graded them all at the same. No, these ones, because the residents got a report after the first video grading, so they were graded at 2 different time points. So there could be bias that they would give people a higher score in that second one. So you're correct in that. They were blinded, though. It was just they could not see the actual person. They could just see what was exactly under the microscope. And then, sorry, the other part of your question was other limitations in...
Yeah, before I address that. So just to confirm that the attending neurosurgeons were all working in trainers in Boston, right? So they have a conflict of interest in the sense that they want their residents to improve, actually, right? So that's the very important bias that you indeed address.
So to correct that, they were actually Italian neurosurgeons.
Oh, okay.
So they were not
so they
affiliated. They did not know the candidates at all, or they weren't affiliated. And then there were three separate graders, and then we did a kappa assessment for inter-rater reliability. So the only limitation in that was that there was truly a pre-test period and a post-test, but they were otherwise not affiliated, and all else was done to reduce bias.
Okay, great. Now my second part was, in what are the general limitations of objective assessment metrics in trying to capture surgical proficiency? Like how do you determine proficiency, and what are the biases there? We regard them as objective, but are they actually objective, like the OSATs, etc.?
Yeah, I think they're way more objective than a surgeon just saying good job, bad job. And the goal was to get more granularity. So the speed with which they could expose, doing the burr holes, turning with a B1, doing the craniotomy, tacking up the dura and that. So time-based is one of the most objective things I think you can do. Other aspects of like, is the dura intact or is it torn? You know, was the sphenoid wing shaved flush? So there's some of that. Some of it was, you know, actually they measured from snapshots of the video, the angulation of the beam.
Esteemed candidates, the time allotted for the defense of your dissertation and the accompanying propositions has now expired. The committee will withdraw to consider its decision. I kindly ask you and your party to remain here in patient expectation of our return. And for those who are online, you will be joining us and we'll be back in a couple of seconds. So we'll be back. Esteemed candidates, having examined the dissertation you have submitted and the accompanying propositions, having heard your defense, and having duly noted the report from the faculty regarding the examinations you have undertaken, we have resolved to confer upon you the doctoral degree. Professor Broekmans is hereby authorized to bestow this honor upon you in the customary fashion. Professor Broekmans.
Uit kracht van de bevoegdheid, ons bij wet toegekend volgens het besluit van de commissie, hier tegenwoordig, verklaar ik u bij deze, Faith Robertson, te bevorderen tot doctor. Ten bewijze hiervan zal u het diploma door rector, secretaris en promotoris ondertekend en met het grootzegel der universiteit bevestigd ter hand worden gesteld. Having thus discharged the duty entrusted to me, may I be the first to address you as doctor and extend my congratulations on the conferral of your doctoral degree. Regard it as an honor and a well-deserved privilege, but never forget the obligation it imposes on you, both towards academia and society. Always conduct yourself in accordance with the principles of academic integrity. Honesty, scrupulousness, transparency, independence, and responsibility. Dear Dr. Robertson, dear Faith, congratulations, and also for your family, friends, and everyone listening online. It's a true honor to give this speech. I told you yesterday that I remembered when we first met. It was at a reception at Brigham and Women's Hospital, and I didn't know that many people, and you approached me, like your dress. Were basically the first words you said. We started talking about neurosurgery versus thoracic, but I'm glad you made the right decision. Science, running, life, etc., etc. And I'm very, very grateful that we've never stopped doing this. As a medical student, you were working then at the Cushing Neurosurgical Outcome Center that we were just starting together with Bill Gormley, who is hopefully online, your mentor who taught you so much and showed you that neurosurgery might actually be a good fit for you. Your energy, interest, and enthusiasm resulted in numerous, somewhat different projects than we heard about today, but all with great impact. Around a year or so later, we unexpectedly met at Cambridge during a session on global neurosurgery. And sitting next to you, quite by chance, we discussed again life, neurosurgery, science, but I said, you should do your PhD. Really, this is something you should do, and let's do it. Let's plan it. And we did it today. And following your passion, you find a way to continue the work you've done in the Philippines, but also what you were doing during your time in London, where you did your master's. I'm so glad you decided to go for it and take the chance and go for a PhD in global neurosurgery, and combined much of the work into the beautiful book that you can be super proud of. Your work has already made a great impact on the field. Yesterday, we asked ChatGPT, who's the most influential person on task shifting and sharing in neurosurgery? And guess what? Faith Robertson, Dr. Faith Robertson, as of today. I think it was not for that reason, because ChatGPT, well, we didn't ask, wasn't around along that time, but our work for task shifting and sharing during COVID time is actually decided by the CDC, just to show what an impact your work has been making and will hopefully continue to make. one thing is certain, your work will really aid in improving neurosurgical care for patients all over the world. Since our chance encounter at Cambridge, you've been amazingly productive. The account of a scholarship section in a PhD has never been this extensive. And you can be super proud of that. Just to highlight for everyone here and online what you've been doing, I will mention some of the things. A master's degree in the UK, you graduated from Harvard Business School, hiked the highest mountains on multiple continents, ran marathons, met with Bill Gates, I forgot, 2 weeks ago or so, gave one of the most inspiring TED Talks on women in neurosurgery, and I could really go on for hours, but I only have 3 minutes. So, but I guess everyone here sort of feels what I tried to say. You're really, really exceptional. Faith, you have been living and you are living life to the fullest. How you manage to enjoy small things like riding your bike along the Charles River to class, doing stadium runs, listening to music with your surgical mentor, Brian, in the OR. Well, it's music. Eating lobster roll after a long day in clinic at the Bark and Crab, or simply lying in the sun at the Esplanade after a super long call. I also learned yesterday that at Harvard Business School, you're known as the person most likely to remove her HBS MBA from her resume to replace it by more important things. So I truly hope that living life to the fullest will continue to be on it. Dear Faith, you're one of the smartest, nicest, toughest, amazing persons I've ever met, and I'm so grateful to be working with you and to have you as a friend. You make an incredible impact on many people's lives, and I'm absolutely positive that you will continue to change the face of medicine. Please celebrate today your accomplishment and live with and life with your family and friends. Congratulations.
It is my most pleasant duty, also on behalf of the university, to congratulate you, most learned Dr. Robertson, on the degree you have so justly been awarded. And before we finish this procedure, we have opportunity for the committee members online to congratulate you briefly, to begin with Professor Rousseau in Washington, D.C.
Faith Robertson, it is an absolute pleasure. Brings me to tears to see what great things you have accomplished. This is a great day for you, a celebration of very hard work done cheerfully and joyfully. It's a celebration for your family and friends and department who have supported you. But I will also say it is a great day for neurosurgery because you are among the best and brightest of our field from the whole world. And I'm just so delighted to know that when our time passes that we will be leaving neurosurgery in your very capable hands. Congratulations.
Thank you very much. And we go on to Switzerland, Professor Schucht in Bern.
Yes, well, dear esteemed Dr. Robertson now, I congratulate you as well. I've congratulated you in the past, and I'm looking forward to the future. I think you are at a great place to do a lot of good in this world, to continue to serve those who are yet unserved, to help those doctors who don't have the means yet. And I hope our paths will cross again and I will participate in common projects. I wish you the very best.
Thank you very much. Dank u schön. We go on to Dr. Van Essen. Dr. Van Essen.
Yeah, congratulations, esteemed Dr. Robertson. I'm very impressed with your work, not only your PhD, but your resume. And we're from the same generation, so obviously you compare each other's resumes, and then I become a little pessimistic about my own resume. I've never met Bill Gates. The highest mountain is where I'm currently at in Austria. And I've only run one marathon, but so continue on this path. I hope to meet each other in the future more often.
Thank you very much. Thank you to all of you. And hereby I declare the ceremony concluded.